Merci Elvis. Bonjour, bonsoir à chacun en fonction de où vous nous joignez. Bienvenue à cette nouvelle édition de Cameroon Town Hall. Nous avons le plaisir d'accueillir aujourd'hui quelqu'un qu'on ne présente plus, qui est très connu de la plateforme Cameroon Town Hall, Dr. Kenji. Et la dernière session que nous avons eue parlait notamment il y a 2 semaines de comment rallier les différentes parties prenantes politiques en plus du ministère de la Santé publique. Et nous avons accueilli ici Dr. Yaouba pour cette présentation qui était très enrichissante. Aujourd'hui encore, nous allons passer à une autre série de sessions très enrichissantes, notamment les fièvres, les dilemmes pour gérer les fièvres en zone tropicale. Et nous allons avoir des informations un peu plus approfondies d'un de nos experts, en la personne Dr. Kenji. Nous avons l'honneur d'accueillir. Bienvenue, Dr. Kenji. Merci encore d'avoir accepté cette invitation. Je vais souhaiter la bienvenue à tous les modérateurs. Dr. Brian Tegomo, bienvenue. Dr. Chairman, Dr. Foma, Elvis, bienvenue et bienvenue à chacun et à chacune de vous. Et merci une fois de plus de renouveler cette confiance à Cameroon Town Hall. Je vais maintenant passer la parole à Elvis pour introduire notre présentateur du jour. À toi la parole, Elvis.
Hi, Christelle. Bonjour et bonjour à tout le monde. Dear members of the Town Hall, it's a pleasure to have you on our 80th edition. It's a pleasure to be here, and I'm always very excited when I'm asked to introduce my own very good and best friend, Kenji. We've come a long way as brothers from secondary, high school, university, and now, and I think he is someone that has been a guest here in the Town Hall, and he's a fervent member of the Town Hall. If Kenji is not able to participate actively in the Town Hall, he prefers to just put his camera and his Zoom on so that we should see his name that he's in the Town Hall rather than just miss it completely. So I think you can see how much passion he has for the Town Hall. So he needs no introduction, but just to know that Dr. Kenji holds a Ph.D. From the John A. Burns School of Medicine in the United States and a Master of Public Health from Manchester Metropolitan University in the United Kingdom, and also a bachelor's degree in medical lab sciences from the University of Boyer. So Dr. Kenji is a board certified lab director, and he has served in very impressive and renowned institutions with a lot of contribution in the field of laboratory and diagnosis. Notably, some of the great institutions he's offered his services there are Illumina, a California-based biotech company, and also Stanford Medicine, as well as a consultant at the WHO. So Kenji holds so many other accolades, which we want to keep it simple because he is a member of the family and a regular in the Town Hall, so we need not spend much time. But before we go to Kenji, I hand it over to our moderator, Christelle, for the next round.
Merci Elvis pour cette présentation sommaire de Dr. Kenji, notre invité. Je vais passer la parole au chairman. Chairman, tu veux dire bienvenue. Tu as un mot pour l'assistance?
Yeah, thank you, Christelle. And I just want to welcome everyone who is here today. It's always a pleasure having you all here at the Town Hall. And I hope my network is good. I just transitioned, so I'm presently in Albuquerque, not in New York. So I'm still trying to figure out how to get things work properly. But I just want to thank all the moderators and also especially Kenji. This is going to be an exciting discussion that I think we need to have in Cameroon concerning fevers, which I think is a discussion that it's time to have this discussion, and we're going to continue to have this discussion in order to improve on our healthcare system and get to better diagnose patients and prevent them from dying. So it's a pleasure having everyone here today, and over to you, Christelle.
Merci, Chairman. Vraiment très intéressant cette session. Il y avait beaucoup d'attentes. Moi, j'ai déjà une liste de questions. Je ne sais pas, Brian, quelles sont tes perspectives du point de vue CDC? Qu'est-ce que tu attends de cette présentation? Tu veux nous dire quelques mots avant qu'on ne passe à Dr. Kenji?
Oh, merci beaucoup, Christelle. C'est un plaisir énorme d'avoir Kenji qu'on ne présente plus. I think today we are addressing one of the most critical challenges that is faced by physicians in in Cameroon, but not only in Cameroon, but across subtropical regions, sub-Saharan Africa. It's one of the most problematic diagnostic issues. As you all know, fevers could be a tail sign of numerous infections. It could be malaria, it could be viral infection, it could be typhoid, it could be just a multiplicity of things. And often we don't have the diagnostic capacities to do that, to draw those diagnostic lines. So it's really an immense pleasure to have Kenji today. I know Elvis made a very brief introduction, but Dr. Kenji is way, way more than that. He was one of those at the forefront of diagnostics during the COVID pandemic. But what struck me the most about some of the things he did at Stanford University was how quickly they were able to identify a sequence and build diagnostic tests so rapidly, so quickly, almost in real time before the US CDC or any other institutions was able to do it. So I think we have a treasure here in the town hall. I have a lot of respect for Dr. Kenji. I've learned a lot from what he is doing, and he's continued to be an inspiration to a lot of other people. He's given back to Africa, to Cameroon. He frequently goes back to give conferences. So I have enormous admiration for his work, and I'm hopeful that today we will have the opportunity to maybe hear more new strategies to how we can revolutionize fever management in our context with the limited diagnostic capacity that we do have. So, Crystal, thank you. Looking forward to an exciting discussion today. Over to you.
Merci beaucoup, Brian. Je partage ton avis parce que nous, ce qu'on sait diagnostiquer, c'est le paludisme, mais la goutte épaisse, le test rapide, toutes les autres pathologies tropicales, Scrub typhus, tous les autres, là, on ne connaît pas. On n'a même pas d'abord de plateforme pour diagnostiquer. Donc, vraiment, je suis très curieuse de savoir comment on peut améliorer, qu'est-ce qu'il faut faire, qu'est-ce qu'on ne peut pas, ainsi de suite. Je vais passer la parole à notre modérateur qui est la docteure Kate. Est-ce que tu veux dire bonjour à l'assistance?
Hi, Christelle, and good evening to you all, and welcome again to this, I don't know, another session of the Cameroon Town Hall meeting. And obviously, I just know we are going to go in for a treat. The topic fevers is something that I'm personally interested in. I know a couple of years back when Kenji visited BTC, we had a brief discussion on how to tackle fevers and how to, diagnose non-malaria fevers. So obviously, I look forward to seeing what and to hearing what we are going to have tonight to learn. In fact, I'm here with my block note, which you cannot see. So I'm just eager to hear what Kenji is going to bring to us today. Thank you, Christelle.
Merci, Dr. Kate. Moi, j'ai un bloc-notes qu'on peut voir. Je vais prendre une note pour nous deux aussi. Et
Okay.
je vais passer la parole à Elvis. Là, une annonce avant qu'on ne passe la parole enfin à Dr. Kenji pour qu'il nous dise ce qu'il veut nous dire. Mais d'abord, Elvis, à toi la parole, Elvis.
It's always a very great pleasure when I'm bearer of good news because it brings smiles and warms my heart. So two good news. The first is one of us in the town hall just defended his PhD, and that's Dr. Kate. We can all give him a very big hand. He is now MD, PhD, and is threatening to have another PhD in theology. I met some boys in Bonamoussadi. They are planning that if they catch him again trying to do the fourth PhD, they'll report and beat him publicly. He has overstudied, and they say, take a break, Kate. But Kate say, I'm unstoppable. So thank you so much, Kate. You have really been really, you've sacrificed and put in a lot to achieve this milestone. So we are so proud in the town hall to have this good news. And so I thought that I should do justice to really make the town hall celebrate you. We celebrate each other when we achieve this kind of milestones.
Thank you so much.
Second good news, the minister was here in the town hall. He announced that he was going to respond to the numerous call for concern that was raised about, difficulties for diaspora to access back the country, to give back to the country, be it in terms of donating their services, their skills or equipment. And there's so many bureaucracy and delay in treatment of documents and just difficult in getting visa. So the minister said, okay, The best way to solve this problem is I'm going to create a special committee in the Ministry of Public Health that will be in charge of the diaspora healthcare professionals. And we are going to make sure this committee is interministerial. It will bring in people from Ministry of External Relations, Finance, and the diaspora. So together, these issues can be resolved in a very, very quick manner. Being a man of action, he went back and did not hesitate to immediately put in place this commission. And you must have read the emails that the town hall sent to all of you announcing that this is now a reality. So I'm announcing to you today that an official text was signed by the Minister of Health creating this committee, in which some 4 members of the diaspora were appointed to join other members from the ministries to be in this committee. So it's a very, very great success for the town hall, for all of you, for everyone who has been a part of town hall, that your voices have been heard. And that is the kind of contribution we are doing back home. The committee or the working group held their first meeting on the 27th of July. And we had a very, very, very wonderful feedback from those who attended the meeting. So the chair has decided that the town hall is going to consecrate a special session just to talk about the committee and to talk about the resolutions that were taken during the first meeting, and to just let you know how exciting this innovation is and how this is going to spur a lot of development for us back home as far as the healthcare system is concerned. So I thought I should take this special moment to make this announcement officially, because we've not done that before, but we hopefully are going to have another better time to have a conversation about this. Without diluting the importance of this presentation for today, I'll pass it over to our main guest to hit the road with his presentation. Thank you.
All right. Thank you so much, Elvis. Thanks, everybody. It's always a great pleasure to be here. It's really true that it's your friend that kills you, and Elvis here releasing some of my secrets that I lock in and I'm not present during the town hall. But yeah, thanks everybody, and congratulations, Dr. Kate, for yet another milestone that you've achieved. Just one moment, please. Let me just make sure I get everything correct with the presentation. Is it okay? Can you see the slides, Elvis?
Yes.
All right. Okay. So today we are going.
Yes, but Kenji, you should swipe.
Yes. What did you mean?
Swap we're seeing the presenter's view, not the.
Yes, good. That's it.
All right. Let's do this. All right. So today we're going to talk about fevers, fevers in the tropics. As you know, this is one of those discussions that we've been having and will continue to have. It's not something so straightforward. So I'm not going to promise you that today I'm going to, give you some kind of a magic bullet that's going to solve all the issues. But what I just want to do is just first of all try to highlight the problem and show some data of what we are seeing in the field, and just the way forward. And of course, the most important part will be the discussion that we're going to have at the end of this, just talking about these things. What can we do in terms of diagnostics and all the like? So to kickstart it, I would like to look at the diagnostic challenges of febrile illnesses in the tropics. Now, I've put in place this picture. If you take a closer look at this picture, you can see somebody's eyes, and you can see a worm that is creeping below the eye. Those that have worked in tropical countries, of course, this is not a diagnostic challenge, right? This can only be one diagnosis, and it is a direct diagnosis. You don't even need the lab for this. And this is lualua, right? It causes filariasis, and you don't need a lot of training to be able to identify it, and you don't need so much infrastructure to be able to make this identification. Now I'm going to show you a second picture. This is one of the participants in one of our study sites over there in Marua. This little girl has been having bursts of fever for the past 10 days. Now, this is a diagnostic challenge, right? Because fever, as you know, is a symptom of many infections. And of course, in tropical countries, you have limited number of healthcare workers, you have extremely high patient volume, and you have few diagnostic services that are available. So unlike the picture to my right, this little girl, if you don't know exactly what causes the fever, it will be very challenging for the provider or for the clinician to provide appropriate care for this particular patient. So I just wanted to highlight these two pictures just to show you, how challenging it could be to be able to diagnose febrile illnesses. Now, the history of fever in the tropics is very, very long. I really don't intend to start from the beginning. But since we are talking about fevers in the tropics, I thought we'll start with this gentleman. He's called David Livingstone. Some of you might have recognized him. He was born in Scotland around 1813. So it's good for us to understand how the Western world viewed fever at that time, just so that we can appreciate what has changed. And Livingstone kept a very good record of his health and everything. And those records, I'm just going to review it a little bit, and I hope you don't mind me entertaining you a little bit of history. So he spent between 1841 to 1871 in Africa, and he kept details about his health and those of his colleagues. And those details are really relevant for us understanding fever more than 150 years ago. And he died in Zambia. And as you can see, the cause of his death was written as fever, right? So it really helps us understand how they looked at fever in that time. So going through some of Livingstone's notes, fever was perceived as a single disease, right? And it was called the fever. I mean, you can even see in this ad, right, where one of the pharmaceutical companies were trying to promote, one of those, drugs that they had come out with for fever. And as you can see, they say a guaranteed remedy for chills and fever. So at that time, it was all fever, right? Fever was not considered to be caused by germs. And you can see here, right, one of those therapeutic agents. It was tonic, and it has like 10% alcohol in it. I'm sure some people, love this kind of treatment with the alcohol present in it as well. So it was just considered as a remedy for the fever. And they thought that this fever was provoked by local conditions, for example, swamps. On the bottom left, you can see Livingstone, right? He was being carried by a bunch of Africans, crossing the swamp, because he thought that when you expose yourself to the swamps, that's how you got fever. Actually, in 1740, the word malaria was coined out, and it's an Italian word for those that have been doing malaria for some time. Mala, which means bad, and area, which means air. So malaria actually means bad air, right? It was not referred to. It was not referred to as a particular infectious agent. It just means bad air, and if you want to take it literally, it means fever caused by foul air in marshy districts. So that's how they saw malaria. And interestingly, during Livingstone's time, if you read his notes, you realize that they were aware that quinine could be used to treat the fever that assumed an intermittent rhythm. As you know, malaria, you have all these paroxysms, so you have fever on and off. So they were able to identify that, but all they were still referring to as the fever. So what has changed? Fever then and fever now. Actually, Livingstone was not wrong. Those environmental factors, those marshy areas, they are good breeding grounds for mosquitoes. Even though they didn't identify that mosquitoes, were vectors, now we've appreciated the role of vectors in it. And now we've appreciated that these mosquitoes, they can carry pathogens, for example, P. falciparum, and bite a host and infect that host with that pathogen, and that host now has what is called malaria. So now our thinking of fever then as a single disease has really changed to the appreciation that, hey, fever is a symptom of a plethora of many diseases, right? So it's not just that concept that we had as a single disease. Now, one of my last slides on history, during the colonial period, health at that time in Africa, or tropical medicine, was mostly focused on the colonial masters. As there was the scramble for Africa, there was also the scramble for African diseases. And, if you go back to your history books, you see that a lot of these colonial masters died of malaria. Then post-colonial period, there was the extension of primary care services to rural areas. And due to that extension of primary care services, there was this adoption of syndromic patient management, meaning that you manage the patient based off on the signs and symptoms that that patient presented, not necessarily based off on a diagnosis, because at that time, even diagnostics facilities were not even available. Actually, in 2006, WHO treatment guidelines for malaria recommended clinical diagnosis. That if you have somebody which comes with fever, and presents signs and symptoms, you should consider that person as having malaria. So this led to that assumption that fever is equals to malaria, and led to a wide spread of malaria overdiagnosis. And this led to not only wastage of precious anti-malaria drugs, but other causes of fever were not treated. At that time, a long time ago, it could be understood because, the prevalence of malaria was extremely very, very high, and you didn't want to miss any case. But now, as the prevalence and incidence of malaria begins to reduce, there are now other causes of fever. So actually, this little girl in our study site in Marwa, she was being treated for malaria for the past, I think, 10 days or so without any remission. And when we're traveling to Marwa, we had bought a bunch of RDTs, including that for typhoid. And we ran one of those RDTs, and behold, she was positive for typhoid, and they put her on antibiotics. And this was like 2 days later that I took this picture with this little girl. So that was like one of the success stories that we had in the field. And of course, I'm not here to question the clinical judgment of any clinician. I'm not even a clinician. I trust your judgment. All what I'm doing here is just provide some evidence if we can look a little bit, beyond malaria. So if a patient is positive for malaria, what do? It is direct. You give the patient anti-malaria. But what choices do healthcare workers face when a malaria test result is negative? So we are going to look at three things: the response by the healthcare worker, the action by the healthcare worker, and the patient reaction. So say you went to the hospital and your malaria test was negative. There are two things that the healthcare worker can respond to: either trust the result or don't trust the result. Now, the healthcare worker does not trust the result. What happens is that the healthcare worker gives the patient ACT. The patient feels satisfied, but the patient is probably still sick because malaria is negative and maybe something else is causing the fever. Now, the second scenario, the healthcare worker is going to trust the result, give the patient ACT anyway to keep the patient happy. Because most often, when somebody comes to the hospital, hey, doctor, you get to give me medicine, right? So if you don't give that patient some medication, it's like you don't know your job. So a healthcare worker may just prefer to do that just to keep the patient happy. But what happens is the patient still feels sick. And of course, the patient is satisfied, but still feels sick. Now, the next scenario is the healthcare worker trusts the result, tells the patient to go away. You are negative for malaria. I can't give you nothing. What happens is the patient becomes dissatisfied and, of course, goes to the next available pharmacy and gets anti-malaria. And the last scenario, which for me is the best, the healthcare worker trusts the result, gives appropriate management for that patient, meaning that look for other causes of fever beyond malaria. What will happen is that the patient will be satisfied and the patient will be well because you are able, to actually, look at that patient holistically to identify maybe other things that could be causing fever, which is not malaria. Now, let's take a look at malaria diagnosis, because one of those things that we've seen in publication is, hey, we don't really trust the result, right? We don't really trust, negative results. Now, in 2006, when WHO made, that recommendation of clinical diagnosis, it changed later on. I think it was around 2010 or 2011, if I remember very well, where WHO now recommends confirmatory diagnosis of malaria before initiation of treatment. And this was in part due to the fear of the development of drug resistance, and also to enable the identification of malaria negative patients for which, further investigation needs to be sorted out and appropriate treatment given. So how is malaria diagnosed? There are several methods that you can use in the diagnosis of malaria. The one that is most common and the cheapest is clinical diagnosis, right? Where you go based off on the clinical signs and symptoms of the individual, which is what, most organizations are now discouraging. The next is to use rapid diagnostic tests, right? You could have your result in less than 20 minutes. And you can use microscopy, which requires preparing a thick and a thin film. There's also PCR, which, per WHO, this should be mostly limited for research use. And right, they're still looking at the clinical value of implementing this. So how good are these methods in diagnosing malaria? That was one of our questions, because let's all see how good we diagnose malaria before we now look at, right, what else is causing, fever in malaria negative patients. So we undertook a study in Cameroon just to evaluate the performance of these 4 different diagnostic methods of malaria. And we did that study in Yaoundé. We also did it in Bamenda, and we went to Maroua to recruit study participants. So patients that came complaining with fever, we did this study a long time ago, about 2015. Patients that came complaining with fever, we recruited them. We were able to recruit 551 participants. From each participant, we collected blood, and from that blood sample, we conducted rapid diagnostic tests on the spot. The clinic, they did their thick film microscopy on the spot as well. So we had both results in the patient's hospital book, and the patient took it to the clinician. Then we also did PCR. Of course, PCR is a very lengthy process. We did this in the research lab. Then we conducted an exit survey for all the patients. So we told you, once you are done with the doctor, bring us your hospital book, just for us to see if the doctor, treated you for malaria, if you were negative for malaria. So that's how we're able to access clinical diagnosis for malaria. So what did we find out? So we did a study in Maroua, Corbisson, and Bamenda, just to summarize everything that we have here. If you look at the prevalence of malaria in our study population by microscopy was 31%. If you use rapid diagnostic tests, the prevalence was much more higher. That was 45%. If you use PCR, it gave you a prevalence of 54%. By clinical diagnosis, 92%. Now, let's take a little dive into this. If you see a place like Maroua, 97% of the participants were given anti-malaria treatment. Same in Corbisson, 96%. Of course, this could be understood. This was a malaria season when we did the study in Maroua and Corbisson. But in Bamenda, right, you have a staggering 86% of the participants that were given anti-malaria treatment. So it looks like it's a practice that went across the board. Of course, this is a low power study. We can't take it to make generalization, as a researcher, but it kind of gives us a proxy of what is happening. Bamenda, for example, the prevalence of malaria by microscopy was just 4%. Just so you don't want to trust microscopy, we did PCR. It was just 5%, right? But 77%, all right, of those individuals were prescribed anti-malaria treatment. So all of this, what's the summary? The prevalence of malaria by PCR was 1.2 to 1.7-fold higher in our population as compared to RLT and thick film microscopy. And 38% of our participants that were clinically diagnosed as having malaria had fever caused by other pathogens. Now, I'm going to dive a little bit as to the strengths and limitations of each of all these diagnostic methods as I move forward, because something like PCR that only picks one parasite, right? What's the clinical value of treating somebody that has just one parasite? Behold, in Cameroon, if we just sample people at random and we do PCR for you, a lot of people are going to turn on positive, but it doesn't necessarily mean that they have clinical disease. Now, this kind of just summarizes the performance of all these different diagnostic methods for malaria. Now, clinical diagnosis, the sensitivity of clinical diagnosis in diagnosing malaria in our population was 100%. This is fantastic. This is great. But take a look at it logically. Just say you have 20 people that come to the hospital with fever. You say all 20 of them have malaria. Of course, even if 5 of them have malaria, you're going to pick it up, right? Just because of that assumption. But the problem here is at the level of the specificity. Specificity is negativity. Now, these people that were negative for malaria, how good is clinical diagnosis in it? It's just 17%. And this is where the problem really lies. These other individuals that are negative for malaria that require other treatment. If you look at RDT, sensitivity was 78% with a very good specificity of 94%. And microscopy was 57% and specificity of 99%. Mind you that the gold standard that we use in this comparison is PCR. And of course, as I said, PCRO is extremely super sensitive. In most diagnostic evaluations, they'll always use microscopy as gold standard. So that's why, so our values here may be different from what you see in other publications because we use PCR. But in summary, right, the accuracy of diagnosing malaria using clinical diagnosis was 62%, using rapid diagnostic testing was 85%, and using microscopy was 73%. So in conclusion, PCRO permitted a detection of 23% of more malaria cases that were not identified by microscopy and rapid diagnostic tests. And this is in part because PCRO is sensitive enough to detect just below 1 parasite per microliters of blood. But WHO recommends that PCRO be used for research purpose only until more evidence is available, right, as to the clinical use of somebody just having 1 parasite and you start treating. Now, RDT detected 15% more malaria infections as compared to microscopy, but again, it failed to detect 12% of cases that was detected by PCR. And, you know, if you compare RDT and microscopy, one of the things you'll find is that no matter how good you are as a microscopist, you're only able to pick up around 50, for the most part, 500 parasites per microliters of blood, right? So the quality of the microscopy result is as important as the experience of the technician that is observing the slides. But however, you have 15% of patients were positive by rapid diagnostic test, but negative by PCR. Now, this is, I don't know, you can say a blessing or a curse. One thing with rapid diagnostic testing is that it identifies a protein that is secreted by the parasite. So you can have the parasite that is cleared, and that protein still remains in blood for about 21 days. So you're going to have this patient test positive, but actually the parasite is already cleared in the patient's blood. So in the absence of PCR, according to our study, you know, malaria diagnostic testing can be used to improve the quality of care. Now we may be like, hey, RDT can meet some cases. So is it really safe for a patient who is negative for malaria by RDT not to be given anti-malaria treatment? Now, that is the next study that we are going to look at. So in this study, 1,000 children with fever were recruited. And the whole aim of this study was that those that were negative for malaria should not be treated for malaria. So you can see 2 arms. The red, you had 40% of the participants were positive for malaria, and you had 60% of the participants were negative for malaria. And to trade on the side of caution, what the investigators did was that they started this study in an area that is moderately endemic for malaria, just to look at safety, right? Before they now went to an area that was highly endemic for malaria. So that is a stratification of the 2 populations. So what you will see is that, so when you came to the hospital and you were positive for malaria, they gave you malaria treatment. If you were negative, they don't give you malaria treatment. Then they follow you up for 14 days. So at day 7, they paid a visit to your home, or you came to the hospital. So by day 7, you realize that 98% of those that were positive for malaria were cured. Interestingly, those that were negative for malaria that were not given malaria treatment, 97% of them were cured. Like they had no signs and symptoms. They had no test positive for malaria. But then, if you take a closer look at the study, you realize that at day 7, you had about 2% of the participants that were positive for malaria that were still sick. But when they did a test for malaria for these individuals, they were negative for malaria, but they were still sick. So it could still mean that, hey, this was a co-infection. So at times it's not only malaria, it could be malaria plus maybe typhoid. And if you're only treating for malaria, right, that fever can continue being caused by typhoid. Now, if you look at these people that were negative for malaria, there were about 18 of them that were still sick at day 7. Out of those 18, 15 of them were still negative for malaria, meaning that it was not malaria that was causing that fever in them. However, 2 of them tested positive for malaria. Now, a lot of explanations could be given for this, right? Of course, the ability, you know, for a test to test positive, it really determines, it really relies on the limit of detection of that test. It could be that these 2 individuals came when the parasitemia was not yet high, then later on it became high, or it was that when they came to the hospital, they were negative. Then as they went home, the mosquito doesn't care if you are just from the mosquito doesn't care if you are just from the hospital or not. It can still bite you, even your way going home. So it could still be that this is an infection that they carried after their hospital visit. But what I really wanted to highlight here is that 2 people died that were malaria negative. So in this arm of people that were negative for malaria, that were not given anti-malaria, 2 of them died, which was worrisome. And these 2 people, they didn't die because of malaria, because they were negative for malaria. They actually died due to sepsis and pneumonia. So this still tells us that, hey, if you are treating these 2 people for malaria, it's not going to help them, because what they have is sepsis and pneumonia, and they probably need an antibiotic treatment. Now, just to further corroborate that previous study, I'm sharing you 2 other studies here. And the outcome here was mortality or case fatality between those that were positive for malaria and those that were negative for malaria. So in the first study, about 14,000 children were recruited. The case fatality was 8.5%. So they were now looking at mortality. So of course, in both groups, those that were positive for malaria and those that were negative for malaria, all of them, I would say about 90-something% of them were being treated for malaria. These people that were positive for malaria, they had a case fatality of 6%, meaning that 6% of these individuals died. But those that were negative for malaria, 11% of them died, which shows that there is more mortality in these individuals that are negative for malaria and being treated for malaria. Now, to further corroborate this other study, this is another study that was done. This one was done in Ghana. The first one, study number 2, was done in Tanzania. And in this case, you had about 17,000 admissions, but at the tail end, I think about 44,000 were recruited for this study. Sorry, 4,474 were recruited for the study. And also it's stratified by slight positive for malaria and slight negative for malaria. And they were looking at mortality. So those that were positive for malaria, at the tail end, 7% of them died. But those that were negative for malaria, at the tail end, 12% of them died. So there's been a lot of these studies that have actually showed that you have more mortality in these individuals that are negative for malaria, and we should really pay attention to. I know I've been talking a lot, so what can we summarize from all what I've said so far? PCR permits the detection of more malaria cases. So that's from our own study that we've seen. And the diagnostic performance of malaria rapid diagnostic tests was better as compared to microscopy and also as compared to clinical diagnosis. Again, no offense to the fabulous laboratory technicians. This result is just based out of a few lab technicians that did the thick film microscopy. There are very great technicians there that are able to pick up, the parasite. And another conclusion is that the accuracy of clinical diagnosis of malaria was really poor. And most importantly, not giving anti-malaria drugs to children that have fever and are negative for malaria is safe, even in areas that is highly endemic for malaria. And the advent of point-of-care tests, these are the rapid diagnostic tests, really pose a challenge to healthcare workers as to what is it that we really need to do if a patient is negative for malaria. Because in our study, 38% of the participants that were clinically diagnosed as having malaria did not have malaria. So what else is causing fever in these individuals apart from malaria? And how do we even know with the limited diagnostic facilities that are available? But the first thing I always say is, first of all, know that there are other things that cause fever, because that is first the awareness. Once we're able to show, we now talk about the diagnostics, right? What can we bring in place to be able to diagnose these non-malaria causes of fever? So causes of febrile illnesses beyond malaria, a survey was done sometime in 2007 in 42 sub-Saharan African countries. And there was an estimated 655 million fever episodes in children less than 5. So it's a huge issue. Now, as the incidence of malaria begins to reduce, right, there's the better understanding that non-malaria febrile illnesses is important for us to take a look at for effective management. But then there is really limited data as to what else is causing fever, right, in children apart from malaria. But I have some data that I'm going to share with you today, because this research, provides valuable information to healthcare workers as to what is causing fever apart from malaria in that particular area, because I tell you, it's going to vary from one area to another. And some of them are going to have seasonal patterns. For example, malaria, right? You have malaria season, you have the flu season, you know, and all those things. But most importantly, this research data is going to help us develop algorithms that can help in the management of febrile illnesses, even based on clinical signs and symptoms. And it also helps, you know, in the development and prioritization of diagnostic tools. So the first study that I'm going to show with you, this was a study that was done in Tanzania, where more than 1,000 children that had fevers were tested. So they did over 25,000 laboratory investigations for this 1,000 children that had fevers. Now, what did the investigators see in this study? That 62% of all the febrile children actually had an acute respiratory tract infection. That was the leading cause of fever. And malaria, the prevalence in that study was just 10% in this population in Tanzania. And if you go further to look at acute respiratory tract infection, they were able to profile all the pathogens, like they went all deep. And, you know, here we can see the different profiles. And in terms of systemic infections, they were able to do all those profiling as well. So this is one of those very comprehensive study that gives us some kind of a profile like, hey, if it's not malaria, what else is causing fever in these children? Because out of 1,000 children, only 9% of them had malaria. So now we're beginning to appreciate that, hey, upper respiratory tract is a culprit. Again, as I said, what is happening in Tanzania? Is it the same thing that's happening in Cameroon, right? The period that this study was conducted could actually have some effect on the data as well. Maybe it was done when it was not a malaria season, you know, and all those things. But let's proceed. Here, we just try to stratify the data according to different age groups. As you can see in the younger population, you see you know, a high burst of acute, you know, respiratory tract infection. And as you move further, you know, to the older age groups, you start seeing typhoid fever and a host of others causes of fever. Most importantly, I really love what was done here. Now looking at the overlap of diseases. So the fact that you test positive for malaria doesn't necessarily mean that it is only malaria that is causing that fever. And this study really shows us that overlap between bacteria and viral diseases. So 9.8% of the participants had co-infection of bacteria and viruses. So you also had co-infection of parasite and viruses. So in a nutshell, out of these over 1,000 children, 22% of them had multiple diagnoses. So it was like malaria and this, or maybe respiratory tract infection plus some systemic infection. And in these, you had, you know, 105 patients that had malaria with another disease at the same time. Now, in Cameroon, what's the situation? Not so much has been done with regards to febrile illnesses in Cameroon. But we did a study in 2015, again, that was in Colbison, in Maroua, and in Bamenda, where we recruited the same study participants that I showed you in the previous slide. So we recruited 551 of them. We did clinical assessment. The doctors did the clinical assessment for us. We collected samples from these participants, and these are the various testing that we did. So we tested for malaria, typhoid, leptospirosis, dengue, West Nile. We looked at enteric infections. So we did stool culture to look for, you know, salmonella, you know, amoebiasis. Then, you know, we also looked at respiratory tract infections, including influenza and the regular culprits. So these are just some pictures from the field. So these are the primary signs and symptoms from our study participants. A majority of them complained of headache, right? So that was the chief complaint from all of them. Again, all these participants had fever or had fever. I think our cutoff was, I think, 24 hours before coming to the hospital. Now, this is kind of a busy slide, but there are a few things I want us to take out of this slide. We are looking at Bamenda, we are looking at Maroua, we are looking at Colbison. If you look at Maroua and Colbison, for example, malaria was the main cause of fever in the children that we saw. But if you go to Bamenda, for example, upper respiratory tract infections were the main cause of fever. You look at the prevalence of malaria was just 6%. And when we talk of the prevalence of malaria, we use PCR. So we wanted to use the most sensitive method, right, to be able to send out this research data. Then again, even though malaria was highly prevalent in like Marwa and Corbisson, you still see, you know, participants coming out with, you know, upper respiratory tract infection. We even had, you know, I think we had 1 or 2 cases of chikungunya virus infection. We also had dengue, and we also had West Nile virus infection. So in our study population, we were able to identify the pathogens that were causing fevers in about 67% of our study participants, which is great, right, to begin with, because this was just a pilot study and we didn't do like a comprehensive, you know, a battery of testing for these individuals. Now, just trying to stratify our data based off on the systems and age group. For those between 0 to 5 years, it was not really malaria that was top. It was upper respiratory tract infections. So you see that this data is beginning to look similar to what, you know, the investigators found in Tanzania, where a majority of the children with fever, you know, were coming up with upper respiratory tract infection. Of course, there was still a, you know, a high prevalence of malaria, you know, in these children as well. And if you go to the lower age group, you know, as well, you begin to see typhoid showing up and a host of others. Then, yeah, we just decided just to profile the upper respiratory tract infections in this group of children. Of course, RSV, as expected, you know, was the #1 culprit in terms of causing upper respiratory tract infections. And you had influenza A, influenza B as well. I must say we didn't do the full respiratory panel, you know, in this case, just due to, you know, funding issues and all the like. But from here, at least it begins to give us an idea of what is happening in Cameroon. Now, co-infection, something that I always like to talk about too. In our population, we saw a lot of co-infections as well. So you have people that were positive for malaria and co-infected with other diseases. And we saw a lot of these in Corbisson and Marwa because it was a malaria season. So during malaria season, a lot of people have malaria, but it doesn't stop you from having typhoid. Actually, you know, the highest co-infection that we had was between malaria and typhoid. But you can see there were people that had, you know, malaria plus upper respiratory tract infections and all those things. So this is telling us that co-infections, if overlooked, can cause unrecognized death. So if you're treating somebody for malaria and the person is not responding to treatment, probably look at other causes. If that person is actually positive for malaria and still not responding, then probably it could be a co-infection. Again, I'm not here to, you know, tell clinicians what to do. I'm just, you know, presenting some data that we have, and I trust, you know, your clinical judgments. One thing that we wanted to do was, since there is this over-reliance on clinical diagnosis, can we come up with a model where we could take all these clinical signs and symptoms, put it in a model and see how can you use this battery of clinical signs and symptoms to predict if it is malaria or not. Of course, our study did not have enough power to do that, but we still went ahead just to, you know, do something and see what we got. And we focus on malaria and typhoid. Then we look at asthenia, headache, and vomiting for malaria. And we did see statistics and a bunch of other models that our bioinformatics team helped with. So what we're seeing here is that somebody with asthenia is 4 times more likely to have malaria than somebody that doesn't have it. Same as somebody with headache was 2.4 times more likely to have malaria, and somebody that was vomiting was 1.7 times more likely to have malaria than people that did not present those clinical signs and symptoms. And when we went for typhoid, we saw that somebody that was vomiting was about 3.4 times more likely to have typhoid as compared to somebody that was not vomiting. But then you see typhoid, you see vomiting showing up under typhoid and also under malaria, right? So there's this overlap. So, you know, we have further studies that we plan to do, which will be big. You know, then we use AI and all those things to be able to have all these probabilities where you can just, you know, narrow down and it gives you the highest probability. And somebody with abdominal pain was 4.5 times more likely to have typhoid than people that did not have those clinical signs and symptoms. Again, please don't take this data with a grain of salt. This was data just from about 550 participants, right? It doesn't have enough power to make some kind of generalized conclusion, but I hope that more studies like this can be done elsewhere so we can pull all this data together to be able to like, hey, because the reality is not every healthcare facility is going to be able to perform all this battery of tests. If you're unable to perform it, and we can give some guidance, right? I mean, not me anyway, probably WHO and other ministries of health has to, how you better triage the patient. I think that would be great as well. I've said a lot. Let's conclude from, what I've said so far. The result that I've presented provides a description of the numerous causes of fever in Africa. And I focus on Tanzania and the study that we did in Cameroon. And of course, non-malarial febrile illnesses should be considered by healthcare workers. And also the possibility of co-infection should be kept in mind by healthcare workers. And however, the reality is that lack of access to diagnostic tests for febrile illnesses really impedes, right, clinical management of these patients. If I don't have the diagnostic tools to be able to diagnose all these other non-malarial febrile illnesses, what options do I have? So in a nutshell, at times you can't really blame people, because if the diagnostic capacity of the lab has not been built so much in that country, we can't really do much. But at times it's just so frustrating how the lab is just relegated, by the side. When you talk of enhancement efforts in most hospitals, right, it's always focused on the ward, on the this, right? Not much attention is being paid on the laboratory and trying to improve, those battery of testing. So how can we resolve these unknown diagnoses faster? It brings me to one of my favorite topics, which is called syndromic diagnosis. The data that are presented shows that a lot of these kids come out with respiratory tract infections. This disease can be classified by systems. So you can have enteric infections, you also have the pneumonia, you have joint infection, you have meningitis, and you have bloodstream infection. So the whole idea here is to shift the paradigm. Instead of, hey, a patient comes and I say, hey, test for influenza. When influenza is negative, you test for RSV. When it's negative, you test for adenovirus. No, let's shift now towards more syndromic based. Screen for upper respiratory tract infections, right? That is where multiplex diagnostic platforms come in, because the signs and symptoms of this patient is consistent with a respiratory tract infection. So you just go directly to do that. However, let me just put it in perspective what it really means in terms of syndromic testing. Just say a patient presents with a non-specific sign and symptom to you as a nurse, as a provider. The clinician is going to have a difficulty, right, trying to manage this patient just based on the clinical signs and symptoms. So what the clinician will probably do is, the traditional way that we do laboratory testing, in most places, is that you order multiple rounds of testing. Maybe you do malaria, it's negative. You do typhoid, it's negative. You do the next and it's negative, right? So you are doing one test at a time, which takes hours and it takes days. Now, when you now shift to syndromic-based testing, there are platforms that you can screen for over 23 different respiratory viruses just within 1 hour, and you have the results. So just to put it in perspective, I know there are some lab people here. Just take, for example, you want to do a PCR to be able to identify, let's say, systemic infections. What will happen is that if you are doing single PCR, it's just one target. So you have one primer target that maybe target Salmonella typhi. You have another target that targets, maybe E. coli. You have another target that target Shigella. So you are doing 3 different tests. So syndromic approach means that you move to all this single testing, then you go more onto what is called multiplex PCR testing, where you take all these primers, you combine them together, and you are able to test for all these different pathogens just in one tube. Now, what's the advantage of shifting more towards syndromic-based testing? For the laboratory, it kind of reduces the need of retesting additional pathogens all the time. And the good thing too is that it reduces the turnaround time, right, of testing. It also conserves resources. I'll tell you, for example, if you want to do COVID, flu, and RSV separately in the US, it's going to cost you about $20 for each of those tests. But if you combine all of them in a multiplex platform, it's going to cost you about $25. So it is really, really cost effective to be able to use that kind of approach. And also it has a huge effect too on antimicrobial stewardship. Study has shown that if you use syndromic based approach, it led to 13% reduction in antibiotic therapy duration, and also 30% direct reduction in antibiotic prescription. And again, it has a huge impact on patient outcome, which for a clinician, this is what you are really so interested in, the outcome of the patient. So using syndromic based testing has led to a reduction of 30 hours turnaround time as compared to the traditional way that we do stuff. Then the stay in the ICU has reduced. I'm sorry. Yeah, sorry about that. We had the train that was just passing by. The stay in ICU has reduced by 3 days as compared to batch testing. Then it has led to 10% increase in survival, right? Just because you are able to identify multiple pathogens at the same time. And cost saving, right? It has led to about $9 in terms of cost saving. So there are several platforms that are available out there. I know in Cameroon, we know about the Gene Expert, right? That can be used to test for multiple pathogens. So this is not only limited to fever. I just thought I should throw this out for you to understand that, hey, there are other alternatives out there. I wanted to show you this by Visby. I'm not endorsing any of these products. This is just like the laboratory in your palm. So this is a PCR test that you can test for chlamydia, gonorrhea, and trichomonas. And this test runs just for 30 minutes, and it's PCR. So what we are working on with the companies and all the like is to have panels like this for febrile illnesses, right? Where you can easily deploy it, right, to resource limited settings. And the cool thing with this, if I remember, I think it is just battery powered. So even if you don't have electricity, you are still able to run it. And you also have like the BioFire that has like all these targets. They have like meningitis panel where you can target 14 pathogens at the same time. You have the GI panel where you can target 22 pathogens at the same time. I'm not saying that we need to replicate this in every place, because maybe enteric infection is not a problem in a given region. But what I'm trying to highlight here is that we really need to advocate for these kind of things to be developed, especially for resource limited settings. Some of these equipments are expensive. Some of the reagents are expensive. But one thing COVID has taught us is that, hey, for us in Africa, it's not as if we can't do it. If you give us the tools, we'll be able to do it. We went through COVID when they implemented PCR in Cameroon and all African countries. We had fantastic laboratory technicians that were able to learn the technology within no time and produce very good, accurate results. So we can do same too in terms of febrile illnesses. And I'm just citing one of the studies that we did here during COVID, where we're able to use this approach of multiplexing to be able to test for the different variants that are circulated. I decided to throw in this slide because this is some study that we did, and this equipment is available in Cameroon. Dr. Kate talked about our work at the Biotech Center. We had the Luminex there, and we're able to do a lot of stuff, right? So we're able to, work on developing a multiplex diagnostic platform for viral hemorrhagic fevers. Because when I was doing my research in Cameroon, that's when Ebola hit, and we thought about that. Where we're able to take different beats and we couple them with different antigens, then we are able to test for all these different viral hemorrhagic fevers, at the same time. And we do everything from scratch. We produce our antigens, we do the cloning, we do the purification, I threw this in because we have lab people here too, and they can relate to how frustrating it could be, when you do your Western blot and you cannot find that band that you are looking for. And, we did all these studies just to show, the limit of detection of the assay that we developed, in terms of using it for serological diagnosis for viral hemorrhagic fevers. We did a lot of precision studies, specificity was extremely very good. One of the reasons why I'm highlighting this is that, it's possible, for most of these things to be developed. And some of those technologies are already there. It's just for us now to, put in more advocacy, right, for most of these technologies to be developed for the management of febrile illnesses. And the last slide here, we actually took antibodies, right, for Lassa, Ebola, Marburg. We mix them together to see the ability of this test to detect multiple infection. As you can see, we had signals in all those different antigens. So I know I've been talking a lot. I've shown a lot of data and everything. Just to conclude, my supervisor always asks me, what's the take-home message? The take-home message here is that not giving anti-malaria drugs to children that have fever that are negative for malaria is safe. That is what the study is showing us, even in highly endemic regions. And secondly, that the systemic provision of anti-malaria and antibiotic treatment may not provide much benefit, right? If you don't go beyond, right, looking what is causing fever in this case. Rather, it can expose, children to unnecessary adverse effects of the medication, and can also drive the development of antimicrobial resistance. And in terms of diagnosis, because there's a lot of pathogens that can cause fever, it's difficult to say you want to be doing one test at a time. So the rest of my research is mostly focusing on how can we develop syndromic point of care tests that you can deploy to resource-limited countries to be able to look for all these other causes of fever beyond malaria. So future plans, as I said, these are a few things that we have in the pipeline. The fever app, which is very dear to me, where we hope to use AI technology, but we still need a lot of data where we want to take clinical signs and symptoms and everything. And you can have an app where it's all right, this patient has this, you click these signs and symptoms, put the age, put a lot of things, and it can give you the probability that it could be malaria is 10%. The probability that it could be this is this percent, right? So this is something is still a long way to go. And one of the books that is in my archives too to release is Etiologies of Febrile Illnesses in the Tropics. And again, where I really want to focus most of my time is trying to see how we can develop point of care testing that can test for multiple pathogens at the same time. I can't end without thanking a lot of people that has really helped me in this journey. Maleke was my supervisor during my doctorate, and most of the work in Cameroon was done in her lab. Dr. Taylor and Dr. Neroka were my supervisors here in the US. And I really want to thank all the directors of the hospitals in Cameroon. We had such a great time with the directors and the staff in Marua, Bamenda, Corbisong, even in Widukum. We did some work there which I didn't show. And the staff at the Biotechnology Center in the University of Yaoundé, we did a lot of work with them. And Dr. Axel, he's the one that trained me on producing all those recombinant proteins. Olivia is the one that initiated me to global health and conducting free work, and Grupa was our guru biostatisticians. And also to acknowledge my other colleagues, Abanda, Sam, Livo, Coco, Elise, and some of my students that work with me on some of these projects, Obasek, Alvin, Beatrice, and a host of them. And family and friends that took care of me. My partner in crime, Elvis, hosted me in Cameroon. Thank you so much. Solange, Ernestine, and my church family, Mike, Julie, and of course, where the money came from. Interestingly, I received research support from the National Medical Research Institute in Cameroon, which permitted me to do the study in Marwa. So I really want to thank the government of Cameroon for sponsoring that part of the study, and NIH, and the Department of Defense. And these are just some field pictures. Field is a very, very fun thing. If you haven't done it, please try to do some field work. It's such a huge learning and humbling experience. And I had the opportunity in Cameroon, the students in the University of Boya, they organized a symposium on fever where we had a nice chat. The Ministry of Public Health organized a seminar when I concluded my study, just to talk to directors of hospitals on causes of fever. And the National Malaria Control Program also organized a day for me, and I gave a talk during the Malaria Day as well. And this is my favorite picture from the field. I don't know if you can guess what happened. We finished from the field that day and I ran out of fuel in my car. So I had to get a bike, right? Go to the filling station, get fuel in this little 5-liter container. And for those that have not yet gone through this, it's not that easy, to open that receptacle where you have to pour the fuel inside. So this was very, very exciting experience. And thank you guys so much. And I look forward to having a nice chat with you all. Thank you.
Wow.
Wow.
Brian, I think it was really great. Merci infiniment, Dr. Kenji. C'était très intéressant. C'est vrai que le chat n'a pas beaucoup bougé, mais je crois que tout le monde était scotché aux diapositives, au beau travail. Et c'est maintenant que nous allons prendre des questions. Le temps que tu prennes un verre d'eau, nous allons prendre un peu la température dans la salle. Nous allons inviter quelques participants à donner leur impression. Je vais appeler comme ça au hasard George et pardon pour la prononciation, Ejede Pang. Comment vous avez trouvé cette présentation? George? OK, nous allons passer à Guang Frank. Vous pouvez ouvrir votre micro. Toujours pas. Dr. Brownhilda, comment vous avez trouvé cette présentation?
Hello.
Hey.
Yes, hi. Actually, I'm sorry. I just came on board now. I'm at work, and so Elvis did communicate with me, so I missed it. I really, I'm sorry.
Yeah.
But I know he probably did an excellent job.
And happy birthday to Dr. Brownhill. So
thank you.
Hey,
Thank you.
many more years.
Thank you. Thank you.
OK. Je vais demander à Dr. Samuel, comment vous avez trouvé cette présentation?
Thank you, Christelle. Oh, I was, I mean, it's almost, I am in the field. So when I listen to you talk and looking towards the end, I am just like, wow, because I am from US. When I gotten up and I see the approach and listening to your presentation, I am like, we need more of this. Because you see, sometimes we just believe that it's only malaria. That's it. When you come, whether you are a child, I remember I was just giving some lecture and I was telling the doctors that if you have a child, pay note of other respiratory issues. And looking at your presentation and the data, this is an excellent job, and I just want to commend you. And my one question to you is on the reagents. If hospitals, especially like you already know, I took note of some of the equipment that you have. If they were to engage in the multiplex testing system, how accessible would the reagents be possible for them to have? Again, congratulations. Thank you for the excellent presentation.
Merci beaucoup. Nous allons passer à la série des questions. Vous avez engagé le pas dans la série des questions. Je vais passer la parole à Dr. Brian pour qu'on ait assez de temps, au moins 1 heure d'échange, pour pouvoir coordonner les questions. Dr. Brian, veux-tu continuer? Merci.
Merci beaucoup, Christelle. Très, très bonne présentation de Dr. Kenji. C'est toujours un plaisir de l'écouter. So if you have questions and remarks, and I think this is a really important subject, one of the most critical challenges of our time in Africa and in particular in Cameroon. I was struck by, Dr. Kenji, I was struck by that slide from Tanzania that you presented that showed malaria wasn't even just about 13%, and even typhoid fever was like 3%. I was so struck, and majority of the fevers was actually respiratory infections. So that was really mind-blowing to me. And when you made the comparison with what you did in Cameroon, I was just we've been treating the wrong thing. So there's definitely a huge gap in terms of increasing the level of syndromic testing that I think you talked about, and I hope we will have a chance to discuss and expand more on that And it also brings a lot of other challenges as well, because when these fevers are positive, are negative, for instance, our healthcare practitioners in Cameroon frequently use, antibiotics. So, and there's a rising threat of antimicrobial resistance, which maybe you didn't talk a lot about, but I think it might be a great discussion to talk about the increased misuse of antibiotic and how that's leading to resistance and all the other problems that we do have. So it's really important, and thanks a lot for your presentation. For those who have questions, and there's several of them that I've seen in the chat, you can just raise your hand. And I'll call you to ask your questions. And I do implore you to please be brief with your questions. Start by giving us a brief introduction of who you are and where you're calling us from. And then you can ask your question as briefly as possible. You can also drop your thoughts or questions in the chat as well, and we will try to address those as well. So thank you very much. I will start with Franklin Malova.
Hey, Brian, if you may permit, probably I'll just answer Dr. Samuel's question just so that we don't get it lost. So it was like, how accessible will the reagents be? I think we've learned a lot already from COVID, right, in terms of supply chain, and doing things like multiplex PCR is no longer an illusion in Africa. A lot of countries are doing it. To take it beyond that, last year, I think December, I was in Ghana, training 23 African countries on next generation sequencing, which is a much more complicated technology as compared to PCR. And in those days, next generation sequencing was like near impossible. But with advocacy, a company called Oxford Nanopore has been able to develop a sequencer that is just like an iPad. And that's what we're training people on in the field, right? And in terms of reagents, we have to get creative. One of the things, one of my colleagues working at is having these reagents lyophilized in such a way that you don't necessarily need freezers. You don't need refrigerators to work on them. And most of these PCR reagents can be lyophilized. Then you reconstitute them, then you proceed to go on. Bogoma and myself, we wrote an article just on how you build all this laboratory capacity in Africa, including supply chain and all those things. I'm going to drop out that link. We really need to sit and think through all those things. I'm not the one to give the solution. We can propose, but the government, the World Health Organization, they need to think and map out all those things, like how do we do with supply chain? Do we need to continually rely on the West to send us these reagents? Why can we not produce these reagents ourselves in Africa, right? But to begin with, I feel like we should be able to come up with point-of-care testing that can diagnose febrile illnesses without any issues with reagents. The one that I showed you, that test for gonorrhea, chlamydia, and all those things, you don't need anything else. All you need is your sample, you put it there, and you are gone. And it tests for everything. And I think that is the way we should be thinking. And I hope that a lot of researchers too, can think more towards that approach of point-of-care tests in terms of development. All right, I'll end there and take the next question.
Thanks. I totally forgot. Dr. Samuel asked a really, really important question. Really, how can we bring this to the point of care? And in your traveling, I know you were in Ghana, you talked about traveling in Africa, across Africa. Have you seen some countries that have in terms of diagnostic approaches that have the most promise in terms of bringing this level of community-based surveillance right to the peripheral regions, bringing these sorts of diagnostic technologies? Have you seen countries, and how do they typically do this? What are some more success stories that you may have heard of or seen yourself that has shown the most promise in bringing this to the field?
Yeah, what I would say in terms of the knowledge, we have very brilliant laboratory scientists all over Africa. So for them to learn this technology is nothing. So when you talk about implementation, I feel like every African country can implement this. You just need one, the political will to be able to do that, and two, the funding to be able to do that. To cite specific countries that, hey, this is like the gold standard in terms of this, I'm not sure I have enough data that I can tell you that, hey, this specific country is doing this. But I was so impressed in Kenya and I think in Tanzania, where I saw that they have the hologic Panther. That is like a monster instrument that we have, here in the US, where you can just do the full respiratory panel, right? So it does that syndromic-based kind of diagnostic approach, right? So there are some countries here and there, but again, is the Panther something that I would recommend to be made to all countries? Probably not. It's a very big equipment. You don't only have to think about the equipment. How about the maintenance contract, right? Service contract could be way, way more expensive than even the reagents itself. So for me, I think let's begin to look more towards that approach of taking most of those things and making it user-friendly in a resource limited setting.
Thank you. Dr. Maloba.
Yeah, thank you, Dr. Brian, for giving me the chance to talk. Yeah, I wish to thank Dr. Kenji for the excellent presentation and for a pertinent topic. As we all know, the etiology of fever is very diverse, and we coming with malaria. Malaria too has a very variety of signs and symptoms, including the respiratory distress that he mentioned, anemia, even some sort of gastrointestinal disorders, sometimes that are associated with malaria, which make it sometimes difficult to precisely say this is linked just to malaria or to other infectious diseases, which is one of the problems. And another thing with malaria that we have done, because I'm also working on malaria a lot, is the fact that, the diagnostic tests that are available sometimes are limited or are not too sensitive and specific. Like for a study that he mostly spoke about P. falciparum. I do not know if they tested for the other type of malarias which are common, but may not be tested, which gives the doctors or physicians a problem to whether they should give treatment for malaria or not. So based on his study, first of all, I want to look at that. He mentioned about two groups, those that were fever and those that were non-fever, and those with fever were given treatment, and those without fever who were not given treatment, he realized that they have two deaths that were caused by sepsis and maybe pneumonia. But in Cameroon, most cases, when children go to the hospital with malaria or no malaria, they always give them anti-malaria with a broad spectrum antibiotic like ciprofloxacin, which tends to clear off the malaria and some of the bacterial infection, but which, as you mentioned, Dr. Brian, that these things are not good because it can lead to some sort of resistance to some of these antibiotics. But I wish maybe another study could be conducted to see if in case, giving this group the malaria and the antibiotics, if in case it reduced mortality as compared to not giving them, just the anti-malaria without the antibiotics. That's something that we don't know if it can be addressed. The question that I will ask is, in the case like of COVID-19, to the best of my knowledge, I know that many hospitals in Cameroon, they focus when you have fever, they just focus just on COVID, like the main cause because of the limited maybe personnel and facilities. So in the case of an epidemic, what can he suggest where there's this influx of too much patient and the focus was just based, like in the case of COVID, just on COVID? How could that be managed in terms of all these diverse methods, this influx, to focus just on one, or to say that fever could be caused by COVID or it could be caused by malaria or that, which is suggesting the syndromic testing benefit, but I don't know how that can be implemented in the case of an epidemic or a pandemic. So that's one question, because, in that case, it will be difficult to try to take this where everyone is really in the shock. My second point is, we did a study on asymptomatic malaria, and we noticed that about 81%, we did that study in a sub-region, and we realized that there were 81% people who were asymptomatic for malaria, but they had a parasite. And after the follow-up study, within 2 weeks, some of these asymptomatic patients were converting to symptomatic, which makes it sometimes disturbing, where this patient, when they go to the hospital, they will say, based on the symptoms, maybe they are not having this fever, but within the short period of time, fever is coming up. So I think that sometimes limiting just to the signs and symptoms, as you mentioned, is not the best approach, because he says like fever should really be taken into consideration sometimes. And then we also have cases of sub-microscopic malaria, where these people, we test them for we did the rapid diagnostic test. Rapid diagnostic test about 50 parasites per microliter of blood. So those that have less than that may not be detected by the rapid diagnostic test, which doesn't necessarily mean they are negative for malaria. And sometimes based on the physician, they may also miss, or the lab technician, they may also miss the diagnosis using microscopy. So as he mentioned, even though PCR is not a method, we actually detected that some of these individuals that were negative for rapid diagnostic test and microscopy were positive using PCR, which makes it another issue. So in this case, how do you tend to manage and counteract this to bring the best for the patients? Thank you. I'm sorry for taking much time and for asking too much.
All right, it's okay, Franklin. Nice. Those are very great questions, and thanks for sharing all your thoughts. Just one correction. Those studies that I shared, the two groups, they all had fever. The difference was that one group was positive and the other group was negative, right?
Okay.
So it's not as if the others didn't have fever. They all had fever, and they now looked at mortality in these two groups of people. The ones that did not have malaria, they were not given anti-malaria and followed over a period of time, and 97% of them were cured and they had no issue. The mortality in that group of people that were negative for malaria was due to sepsis, right, and pneumonia, as you rightly said. So you asked if PFAS, Suparum was the only one. No, I didn't show all the data. It's a lot of data. We also saw malaria and overlay as well, but it was just a very tiny proportion of it in our study population. Then epidemic and pandemic testing. Of course, if there is a pandemic, you really want to focus on that pandemic to, to slow down the curve as much as possible. So in that case, that's why you see a lot of rapid diagnostic testing for COVID, but it doesn't mean that because there is COVID, malaria goes away. No, right? At times too, it's the responsibility of the clinician and the public health people to be able to make that determination where should we really, focus our attention in. But all in all, where all of this is driving at is that if a patient is in front of me, I want to manage that patient holistically as much as I can with the available resources that I have, right? If I don't have any way to test for other causes of fever, that's what it is, right? Maybe those tests are not available in that facility. Maybe I need to refer this person to another facility that has blood culture, because probably the patient is already picking up high fever, and all those things. Then I know you also talk about submicroscopic malaria. Yes, that's a reality. No matter how good you are as a microscopist, you can't get to that one parasite. But what we really need to ask ourselves is it getting to that one parasite that is important, right? Because at the tail end, you can carry 10, 20, 100 parasites, but it's not causing any fever. This is an endemic disease. So you always see people carrying it, but it's not causing a fever in them. Do they really need to be treated? It depends from which perspective you are asking. Maybe from a clinical perspective, maybe not, because at that time they don't present nothing. But maybe from a public health perspective, maybe yes, because are those people able to still transmit, right? If a mosquito bites that person, can it transmit the parasite to another individual? All these, I'm not the best expert, right, to tell you about, all those mode of transmission and all the like. But where we are gearing at here is that I know you're a lab person. There is no diagnostic test that is perfect. Let's not over zoom in too much on malaria, because even the other tests that we use, even for COVID, it's not all of them that are perfect. Tests do have their limitations. It's for the public health individuals in that country to do their evaluations. Each WHO does evaluation of RDTs, and they have to certify that this RDT meets the minimum requirement. It also goes to those countries that are also responsible to do an evaluation and recommend which RDTs to be used. But then you have fluctuation, you have RDTs floating from all over the place that have not been evaluated. You don't even know if they work or not, right? Nobody really regulates, what really comes in. But most of the data that we've seen shows that RDT is probably the best way to go. The limitation of RDT really comes in terms of quantifying, because every clinician, Dr. Foma is here, once you can quantify, they are happy. When you cannot quantify, it's difficult to monitor response to treatment. I want to know if the viral load is decreasing, right? I want to know if the bacterial load is decreasing, and and all those things. So I hope probably I'm able to answer some of your questions. If not, you have my number. You can call me and we discuss more.
Yeah, for sure, Dr. Kenji. Thank you very much. Yeah, I think I'll write it behind. We have things to talk about. Yeah.
Sure, thanks.
Yeah, just to add one point, the importance of building a national syndromic surveillance systems is critical as well. The kind of surveillance testing that Dr. Kenji described, I think really highlights on having confirmatory tests for some of these pathologies. If we can bucket the symptoms that are similar and sort of study trends in terms of specific symptoms and have these in buckets and track how those are changing over time, that's a very solid public health monitoring system that could be in place. But Dr. Kenji, just one quick point. I know Dr. Professor Bacham did a study a few years ago on HRP, histidine-rich protein microdeletions, where people can have very high parasitemic load but still be negative on the rapid diagnostic test. I'm just wondering, I haven't followed up on that, and I know there were quite a rise in HRP microdeletions in Cameroon. I'm just wondering how that could clinically impact diagnostics in this context.
Brian, you read a lot. Yeah, so yeah, that's a very interesting question because so HRP2 and 3 deletion, that is one of the limitations for rapid diagnostic testing. So the recommendation from WHO is that if you have a prevalence of HRP2 and 3 deletion greater than 5%, right, that is when you should start considering doing that switch. And also Fine Diagnostics and WHO have also evaluated a bunch of RODTs on their performance with respect to HRP2 and 3 deletions. And some of them are still performing very well. Not all malaria rapid diagnostic tests are created equal, right? There are some that look at HRP2, 3, and also P falciparum specific LDH. So those ones are a little bit more expensive in such a way that if that deletion is there, it's still going to test positive because it's also looking at, so what do you know, the way you as a clinician, Brian, you're going to treat with combination therapy is the same tool for the lab, right? Having multiple targets is the same tool for COVID. Instead of targeting just this particular gene, you target multiple, right? You have the N, the S. So if there's a deletion or a mutation in the N where a primer has to sit, you still have the S that's going to test positive. Yeah, so you have different mix of rapid diagnostic testing for malaria that some of them still perform well in the prevalence of HRP2, 3 deletion. I'm not sure what the prevalence is in Cameroon, but it could vary from one region to another.
Thanks. I don't read a lot. Dr. Mono.
Oh, thank you very much. I think I'm going to make some comments and also try to ask my question at the end. The reason this to me is one of the most important presentation that is dear to my heart, because I come from a background of laboratory. I think back in 2014, when I was doing my clinical pathology, I had to go present in the Bamenda Regional Hospital on this topic. And the reason I did that was because, especially with the data we have that Dr. Kenji presented is in children, mostly. In adults, we have a similar problem and worse because of the way our clinicians were trained in Cameroon. We don't have a culture of even sending blood cultures and doing other differential diagnosis in adults. We have a culture of treatment which goes to the point of even giving anti-malaria and antibiotics spontaneously to patients and goes to the whole topic of antibiotics stewardship, which I think is going to be another day discussion. So Dr. Kenji, I want to applaud you for bringing up this to light, because I think the best first step is empowering the labs. I could tell you very well, trained as a clinical pathologist, our labs are not empowered. RDTs, there was a research, I can tell you this, and WHO takes into consideration the HRP 1, 2, and 3 deletions and gives recommendations to the nations on what kind of RDTs to use. They have been shown to be specific more than 98% of the time, and sensitivity is very high and specificity. Doctors need to start believing those results. When they are negative, 98% of the time it's negative. There's some other cause for your fever. The problem is how many of us do send blood cultures to our patients? How many of us do check other causes of fever and we look at it? How many of us think about this? And what's the prevalence of ciprofloxacin resistance to typhoid? Ciprofloxacin covers a lot of Pseudomonas and many other infections that it's going to treat. We have destroyed ceftriaxone as a third-generation anticephalosporin in Cameroon, totally destroyed. This medication has been destroyed. The level of resistance, no one has done it, super high because we totally destroyed a third-generation cephalosporin by making it available, prescribable by everyone without any evidence of what we are treating, because we're treating typhoid. And you could see the data that was presented to you by Dr. Kenji. I'm giving this reflection because it's something that has been really dear to me. And the reason I say this is empowering the lab, getting us to test, if possible, getting multiplex platforms in place. The question I'll ask Dr. Kenji, how does he think this can be done even at the level of our health districts? I know in the hospitals that can be done. That's my one question. Now I'm going to go into something that is very dear to me, is more of sepsis. And Dr. Kenji said those 2 kids that died was sepsis. The management of sepsis is so specific that every doctor needs to think about it. We need to have an algorithm in place. If someone comes in with sepsis and you rule out malaria and you think this patient truly has sepsis, how many of us do send cultures? How many of us have the ability to want to send cultures to see, even when they are possible? I could do culture in Mancon. In a SEMA or a district hospital, cultures can be done. How many of us do treat these patients adequately in order to prevent death? There is just so much reflection into fevers and what is the cause of fevers. Most of them will be viral. That's why a lot of our patients did get well. When they were RDT negative, without giving them anything, 97% got well because your children, majority of upper respiratory tract infection in children are viral. But those who surely died were those who had bacterial infections, which was resistant to the antibiotics that were being given people. I'll give you this. So in a small hospital, there are multiple hospitals I've worked in. There are small hospitals, I don't know exactly, I'm no longer in the field of laboratory, but there is the multiplex that is done for viral infections. In my hospital, it used to take less than 5 minutes. You see all the more than 20 viruses, it tells you it's negative, the guy is still having fever. And this leads to really the doctor or thinking about this could be sepsis. While trying to investigate sepsis, there's initiation of antibiotics quickly and de-escalation after getting cultures and also providing IV fluids to these patients. So it's super important for us to really get to a point where we can, back home, we can make good use of this and understand that truly fevers are multifactorial. We are transitioning. We are getting to a point where in the Northwest region, malaria is just going to be less than 10% of those fevers. As Dr. Kenji presented, data doesn't lie. So Dr. Kenji, my question is, how do we, I'm coming from both clinic and from paraclinicals because I spend a lot of time trying to empower paraclinicals in multiple areas. How do we make our clinicians understand that the lab is important? Investing in the lab is super important in order for us to be able to diagnose patients adequately, and also making sure that not only in children, but in adults, we do blood cultures and we de-escalate or escalate antibiotics based on those results. That is my one real question for you. It's just a reflection. I want you to tell me what you think. You've worked in that setting, I've worked there. What you think we can do in order to help our clinicians in that light?
Well, that's a $1 million question, Dr. Foma. And I think if we had the answer, we should have already done everything. I mean, for me, first is education. right? That is why talks like this are important. I'm not sure how often we really sit on some of these conferences and just discuss fevers. We sit a lot and discuss a conference on tuberculosis and all those things. I don't think the burden is that high as compared to febrile illnesses. So I think a good starting point is first training from the medical school. I didn't go to typical med school, so you went there, you understand how your training is. Are those curriculums geared towards just looking beyond malaria in terms of when you are doing a pathology or infectious disease courses? Coming out on the field too, doing all this rotation that you're doing, because most likely if I'm an intern and I do my internship somewhere and I see that that's what's being done, most likely I may tend to mimic that way because I think that that's the right way. So it's something that might have gone a little deep, but I feel that with more education, continuous medical training, maybe that could help. With no offense to any clinician, I worked in the lab in Cameroon. There is always this superiority that doctors will have over the lab. Let me call it the way it is, right? And you can argue me anywhere, right? It's always like, at times, it's like the clinician is wrong and, you know, the lab, you're really doing nothing. I actually saw this firsthand where a lab technician was actually quarreled, where we did our study in one of the regions. I don't want to call it just to make it anonymous, where the lab technicians were very happy that we did our study, because all through they were having all sorts of queries that they were giving negative malaria results. Right? When we now came, we did the RDTs and PCRs and all those things, it kind of confirmed what they were seeing in the laboratory. So I think one thing too is for us to see ourselves as team players instead of, hey, you know what, I called a shot here. Instead of collaborating with the lab, hey, malaria is negative, or hey, it's okay to question the lab result. Here I see it a lot. I have queries all the time. They question the result. Dr. Foma, you know, and those that work here, you question the lab result, you talk with the pathologist or you talk with the director of the lab. We may need to go back and retest. So it happens. The lab can still make an error. You know, the lab is not error-free. But what is most important is for us to work together. All right, it's not malaria. What else can it be? Saying that you don't know is not a weakness, it's a strength. But at times it's difficult for some doctors to say that I don't know, or to seek the opinion of a laboratory technician, probably because the person doesn't carry, you know, a doctorate degree and all those things. These things are painful, but we have to talk about them. We have to talk about how we can be more collaborative in the hospital and see that fusion between the clinical arm and the medical laboratory arm for us to sit like, hey, what are we seeing? Okay, doctors, what is it that's going to make your life comfortable? In this region, what you're seeing is more systemic infections. All right. Point of care testing device for systemic infections. Should that where we should focus our attention in terms of building? Maybe we will not have a multiplex. Maybe we can look at biomarkers, procalcitonin. You talk about sepsis, you know about procalcitonin, right? You could use some of those biomarkers as a proxy. We actually used it in our study, right? As a proxy, you know,
lactic acid, procalcitonin,
lactic acid, and CRP, right? So those are some indirect ways, but how, see, CRP is just a CAT test, right? Lactic acid is easy, procalcitonin too. So is it like some of this knowledge doesn't get right across, right? Of course, as I said, I'm not questioning what anybody does, but we need to talk about these things and see how we can make those improvements.
Yeah, so let me give, I'm just going to add something before we go to the questions because it's important. There is, you know, when you study a healthcare system, you get to see where priorities are. Cameroon generally lacks in disease doctors among all specialties in internal medicine. There is just a belief that every general practitioner is a specialist in infectious disease, which is a total fallacy. And that is one of the reasons why we are putting ourselves in this situation where we are. Medical students are being trained, but there are no real infectious disease specialists who are in these medical schools to train them. Because the old colonial training method was that everyone was trained in infectious disease, but there is a shift. And this dynamic shift has not been translated into the academia. Few infectious disease specialists exist in internal medicine. In pediatry, yes, but in internal medicine, no. And this goes up to the point of even training and the approach, even to antibiotics, stewardship, and understanding what to do with antibiotics. I'm going to say this. The next real thing I want to say is also is going to be a reflection. The typhoid test is a whole lot of discussion we can have from morning to night. What is the specificity of this test? What is the sensitivity of this test?
Yeah.
Why is this test useful? What can we do? What typhoid? It's true typhoid exists in our environment, but how do we diagnose it? Is it overdiagnosed? This can be a whole, is it underdiagnosed? Is what test is the best test? I know everyone gets ciprofloxacin. Everyone gets maybe ceftriaxone at a certain point, which is going to treat that disease. But are we really, especially in adults, everyone gets a Vidal. If Vidal is positive, and that's why patients move with their books and tell you, I have that, my typhoid is back. Is this my typhoid that patients own? And really, this comes to a reflection, other means of sepsis. I have diabetic patients with a diabetic foot ulcer who have gone to the hospitals having osteomyelitis. Nobody has ever done a culture to figure out what is growing. Even they have sepsis, a lot of them. They are lucky that they got ceftriaxone. They got a machine gun therapy that we used to do in Cameroon, ceftriaxone, machine gun therapy. And the problem with antibiotics, with time, I would invite someone to really come here, maybe Kenji, you or the others, Boguma and the others, to come talk about this topic, and we get a continuation of this discussion. Thank you, Brian. I'm sorry for taking.
No, that's fine, Mono. It's always a pleasure getting your perspectives. Dr. Kate, please.
Thank you so much, Brian, and thank you, Kenji, for the presentation. And I think I'm just going to continue from where Mono left and just really highlighting that because of antibiotic resistance, you talked about antibiotic stewardship. That machine gun therapy is no longer working. Because from our survey, we see that people with diabetes who are dying in our hospitals today are dying from infections, and mostly from diabetic foot infections and contaminations and complications, sepsis. And secondly, Kenji, you talked about procalcitonin, which has always been something in my mind. Because I'm interested actually in that 2% of children who are dying. It looks like something small, but something big. So I, as a researcher, am interested in that group that is RDT negative. There is some data actually showing that in our clinics across Africa, if you test positive for malaria, you risk going home with anti-malaria and antibiotic treatment, so about 17%. When you test negative, that percentage almost doubles. It goes up to about 30–35%. So you would go home with antibiotics and anti-malaria, even when you're RDT negative. And so that brings me back to the whole issue of procalcitonin. And I remember I talked to you about what can we do? I believe in POC. Can we do a bi-POC plex, where we call it that way, where we stick anti-malaria on the capillary flow line on one side, we have the procalcitonin antigen on the other side, because that can at least, because now we have, I think, semi-quantitative forms for PCT, and that can at least guide clinicians, because if PCT is positive, then the probability that there is a bacterial infection is very high. Now, the level of the positivity, there are issues there. So I don't know, I just want to throw that back to you and just to hear your thoughts, and probably we'll take that further offline.
Yes, we'll take it further. So actually the last slide that I shared with the RDT, I had several targets on it. I just took it off because that's something I'm working on. So yeah, so that quadriplex, right, where you have a stick where you could have this and it. The challenge may just be, sample type, and all those things. So it's totally, possible to have all of that. And, just to show the clinical value, right, of, implementing procalcitonin, point of care, lactate and all those things too is great. So yes, it's possible. And of course, yes, we can talk about it. I'm looking for all, sorts of collaboration, because now I'm shifting a little bit more towards, the traditional PCR test development, focusing more on how can we now take all these things we've developed and bring it, in a low resource setting in such a way that we are able to do this syndromic based kind of diagnosis. It's going to help everybody. It's going to help the lab. It's going to help the clinician, because seriously, I get it. If it's not malaria and this patient is presented with clinical signs and symptoms, then you don't have any other test that you can offer to this patient. What do you expect the clinician to do? I really want to be sure that, this patient doesn't by mistakenly, die because of probably malaria. Yeah. So there's a flip side of that, right? We are not saying that, that practice is correct. It's good to look beyond it. But one thing too is just to look at the referral system in the country. How does it work? If I'm unable to handle something at this level, can I refer it to another level? Not every hospital will be doing blood culture. You can have it at this level hospital where, you can refer those patients to that hospital for them to do blood culture. Not every hospital may do the full respiratory panel. Even here, not every doctor requests full respiratory panel. At times, most of them just want COVID, flu A, flu B, and RSV. That's the most popular, right? The other ones, adeno, metapneumovirus, and all those likes, some will not request it because they know, hey, if this is the most, like the likelihood of having one of these four is high. So that is why the epidemiology of these infectious agents in a particular area is very important, because from there you can start narrowing it down to what to do. So I hope that many more people, including you, Gatti, you work on diabetes, but infectious disease too is still part of what you do, because diabetics too, have all these infections, on the foot and all the like. So I hope we can all continue to advocate. I always give an example. When HIV just started, CD4 count was just for the rich. People that could afford CD4 count, you had to be super rich. The machines were very rare, but now you have all these little point of care CD4 machines. And all this came as a result of advocacy. So we can also advocate for things like that, all this point of care testing to be developed, right, for low resource settings, and approach all these big companies like BioFire. I think they are like the best now in terms of syndromic based diagnosis. I feel like they have everything from respiratory to meningitis to enteric to blood culture, and online. All right, thank you.
So, Kenji, what's going to be your take? Just a little follow-up question on using Bayer. I've seen that being used in our labs here for cultures in order to get culture results quickly, and that be implemented in Cameroon. Like,
it can be
cultures are done.
Yes.
Cultures are done, but we get the results immediately telling us which is positive.
Yes. So
we get the results within hours. I think within hours.
Yes. So if you look at one of my slides, I said it has reduced the turnaround time by about 30 hours. I was mostly referring to blood culture. So now most labs, like here in the US, once the blood bottle turns positive, because we use the BACTEC, you just take just a little bit of it, do your gram, you take a bit, put in that pouch, you load it on the BioFire. Within 2 hours, you have a profile of all the pathogens. Dr. Mona, to run BioFire, right? I'm a lab person. Seriously, it doesn't need any rocket science. It's point of care. Even the nurse can run it.
Yeah, because I know in my lab, there are people who have no real level, even in the US. They just run it. They don't have any level of training. Yeah.
Yeah. It's not that complicated, and we have very smart people in Cameroon. The thing now is, hey, why can't we think of, all right, let's approach these companies. Somebody needs to take the lead. Can we do a customized version of what you're offering in the US market to the African market in such a way that, we make the reagents more lyophilized? It doesn't have to meet all these whatever standard, that they are setting and all those things, but we still do our own validation in such a way that it fits into our context. So that advocacy needs to take place. One person cannot do it. It needs to take a lot of voices, a lot of organizations, a lot of researchers to even think of alternative ways. It's the same too now with urinary tract infection, right? There's a new technology that is coming up where you get your urine sample, you don't even need to culture, right? You get your urine sample, you put it in the device, it look at all these biomolecules, and it's able to tell you it is E. coli and give you the antimicrobial sensitivity. In 2 labs here in the US, I helped them implement PCR diagnosis for UTI. So they're no longer doing any culture. They're all urology practice. The patient comes, we draw the sample. So we have a panel, I think we have about 35 targets in that panel. It looks at all the most common pathogens that can cause UTI and the most common resistant genes. So you now take blood culture that used to take like 48 hours, 72 hours, you do it in 2 hours and you have all those results. So it's possible. The good thing is that most countries now in Africa have the thermocyclers because of COVID. So now we need to start looking beyond COVID. How can we make better use of those thermocyclers? To do a respiratory panel, you must not go to biofire. We can still develop those tests and you run it on those thermocyclers that you already have. Of course, it's not going to take 30 minutes like biofire. It will probably take 2 hours. But of course, it's still fine. It's better than nothing. So I think one of those discussions sometime that we can have a subgroup of laboratory personnel here. And in Cameroon, it's like all those machines that we got because of COVID, how can we repurpose them to diagnose other infectious diseases?
Thanks, Kenji. There's someone that made a comment in the chat, which I think is very important, which I would like you to, if you could address it. It's Ndamsi Fujio Valdo Vadel. I don't know if she would want to ask the question directly, but she made a comment around the fact that as providers, we tailor our medical approach based on the patient's financial circumstances. So we often have to accommodate really diverse financial circumstances for most of our patients. Many of them clearly don't have the resources to do more advanced diagnostic testing, some of the things that you did talked about. So how can we strike a balance between our desire to provide high quality healthcare and also consider the economic realities of most of the patients in our context? How can we strike that balance?
Mm-hmm. So what I would say is a very good question, and it's a reality, right? That you really want to manage this patient is the same as doing a scan, and the patient cannot afford the scan, so you cannot proceed. There is a difference between the patient not being able to afford and you not wanting to look beyond malaria, right? In terms of managing these patients with febrile illnesses. That's a reality. If the patient cannot afford and there is no organization that can cover the cost of the laboratory test, of course, the doctor will use his or her best judgment based on the clinical signs and symptoms. That's why they are trained, right? To be able to know what is the most, probable pathogen. The doctor takes no fault there because that's just the limitation of the society we're working with. But I think in as much as we are looking at short-term, the long-term goal and the most effective way will be how can we develop these diagnostics in such a way that they are affordable. For example, malaria RDT is affordable. I still give the issue of CD4. Before, to do CD4 was extremely very expensive. I'm sure it was almost 30,000. But I think now, the last time I checked, I think a long time ago, it was like 5,000, 3,000. Yeah. It's left from 30,000 to 3,000. So it's also possible with these other testing, but we need advocacy. If we can do it for CD4, which is much more complicated than testing for typhoid or leptospirosis or this, then we can do it for other febrile illnesses alone. But of course, as I said, we all have to come together and try to advocate for some of those things. And I hope researchers too in the field of diagnostics can, flip the switch a little bit. Instead of thinking of the conventional PCRs and all the like, let's think more towards, point of care testing.
Thank you. Christelle, tu as la parole.
Merci beaucoup, Brian. Dr. Kenji, I think it's just a comment from my end. In one of your papers, you presented that among patients were smear negative for malaria, almost 60% were dengue positive among smear negative. So if I'm not wrong, and then I think for my tropical medicine courses. We have courses of fever like dengue, scrub typhus, leptospirosis. So I was wondering why you are working in the industry on building a point of care diagnostic tests, whether these diseases could be incorporated in a, I mean, it's one, I don't know how to do it, but I'm just thinking aloud there. Something that at least you can take. I totally agree with the syndromic based testing is very important. Definitely we have to go towards it. And then, but if you have something like you use one sample, but you are able to screen for approximately 3 to 4 diseases that we know have the same symptomatology, then it'd be really great for the field. Thank you so much.
Yeah, so Christelle, thanks for that question. Just to let you know, there's a rapid diagnostic test for dengue, and we used it in Cameroon during this research. Right, yeah, so we did the RDT for dengue, even leptospirosis, there's an RDT. Then we now went to the lab and we did serology, where we did a, we did use now Luminex and all those things, did the print assay, virus neutralization. I didn't show all that data. Yeah, but there's rapid diagnostic test for dengue and it is standalone. Again, talking about dengue and other fevers, if you look at what we're trying to develop at Biotech Center and also University of Hawaii, the multiplex assay that we're doing was for hemorrhagic fevers, right? So because you need to be able to filter them. You can't just say fevers. You can't develop one thing that covers everything. So you have respiratory, you have enteric, you have systemic. Now just say there is an outbreak of hemorrhagic fevers where people are beginning to bleed out of the orifice and all those things. You can now use the hemorrhagic fever panel, which will cover Ebola, which will cover Marburg, which will cover dengue, right? And any other pathogen that can cause, hemorrhages. And this is not a panel that you'll be using all the time, right? Because I don't think hemorrhagic fevers are things that, occur, that often. But again, with dengue too, you need a good clinical suspicion because, most people that have dengue will not have symptoms, and almost 80% of them are going to have no clinical disease. You have a few that can proceed to, dengue hemorrhagic fever, and the worst is the dengue shock syndrome, right? Due to all this vascular leakage, and all those things too. Yeah, so that's what I can comment there. And if you may allow, just to thank more people too. I see Guang Franklin. He also helped a lot too during my research, and I see Estelle as well on the line. Those are some of my students as well that really helped with some of this work that we did.
Absolutely. Thanks. And Christelle's question kind of reminded me of this emerging threat of climate change and how climate change is changing the patterns of disease in Africa, and how we should probably be thinking more about how can we adjust diagnostic strategies to accommodate for emerging infectious diseases and things like, what's happening with vector-borne diseases and, and transmission and those patterns. So, yeah, I do think in Africa, we definitely there's a great need for us to adjust our diagnostic strategies to accommodate for some of those climate-based, infectious disease threats as well. Just the last question from the person whose hand is up. I know the name was Kenji, but I just renamed it anonymous. If you can present yourself and ask your question, please.
I think the person is on mute.
Oh, you're muted if you're speaking.
Oh, sorry. Can you guys hear me?
Yes.
Hey, this is Isabel. My name is Isabel. Let me start by saying excellent presentation, Dr. Kenji. That was a very, very, awesome presentation. I wish we would have more people conduct such research in Africa and in Cameroon in particular, because it's going to make a huge difference if we can eventually use that data to affect change in Africa and in Cameroon in particular. My hand has been up, and there is one thing I was going to talk about, which Brian actually talked about, which is the economic burden on the, like looking at the indicators of health. Money is a big problem in Africa. Many people, I'm going to talk as a clinician, I have a patient who comes to me and say, hey, I have fever. I only have 1,500 francs to treat this fever. Now I have to start thinking, what am I supposed to do to help this patient with just 1,500 francs in their hands? And that's why we see these providers just prescribing broad spectrum antibiotics just to cover whatever they can cover so that this patient can feel better. It's not what they are supposed to be doing, but the reality is it's really, really different. And like you said something very important, which is are the providers prescribing that way or treating that way just because the patients cannot afford, or it's because they are just being biased towards malaria? Like anybody who presents with fever is malaria. But I think we are dealing with a population where finance and money, it's a big issue with managing disease conditions. The other thing I was going to say is with the healthcare system as a whole, having worked back home and now working in the United States, I would say we really need to come up with protocols for managing disease conditions. Back home, we don't have a lot of protocols. You have a patient who comes in, what should I say, chest pain. Nobody is thinking about doing an EKG. That's the first thing you should be thinking. First thing is EKG, troponins, cardiac markers, those kind of stuff. Back home, there was nothing like that. I went through school back home, maybe not as a medical doctor, but even as a nurse abroad knows that the moment a patient presents with certain symptoms, there is a protocol you start running. If a patient presents with SIRS, which is mainly three things: hypotension, low blood pressure, respiratory rate greater than 20, heart rate greater than 90, temperature greater than 38 or less than 36 degrees Celsius, you're already thinking sepsis. Whether it's sepsis or not, you're already thinking sepsis. First thing, what am I doing? I'm drawing blood cultures. Nobody has to tell you that. It's a protocol. You should know that. You draw the blood cultures even before they start treating the patient with any antibiotics. That way, if they have to do the sensitivity on that, that specimen, the antibiotic is coming after the sample has been drawn. So I think that's something that, I don't know, we have a systems problem, but the curriculum and the training has a big part to play in the whole thing. Coming up with protocols is very, very, very important. And just to reiterate on what you said about the syndrome-based panel testing. I don't know if I'm saying it right, but I think that's the way to go to minimize cost and wasting time. You test for malaria, is negative, then you go test for typhoid, is negative, then you start thinking, what else? If we can really come up, I don't know those who are in this panel, this is this very second time I'm joining this, and every single time I've been on here, it's been, really good. So I'm hoping that some of the people who are here can advocate for the people of Cameroon, the indigents, those poor people. Use your powers wherever you are to say, hey, these are the recommendations and how can we start implementing these things? If we talk and talk and talk and we don't take any action, then it's not going to make any difference. I'm really hoping that those who are here and especially back home can please use this information to benefit people. Thank you all so much. It's been awesome.
Yeah, thank you so much, Isabel, for your contribution. And you come from, two perspectives, having worked in Cameroon and worked in the US to what can improve. One thing I want to talk about finance, at times it's really relative. I love my students so much, but there was one time I asked them, who of you here has gone to do your glucose tests, right? When I was still in Cameroon. Oh no, probably it's expensive, it's 2,000. Then I walk down the street and I have like 10 bottles of beer in front of them that they've been drinking. And it's going to cost like 4,000 to drink that amount of beer. So one thing to really need to get to that point too, where we become more aware of our health and understand that if you are sick, you are not going to work. So take two things. Isabel, in terms of the finance, you have somebody who has a car. If that car breaks, that person will probably go and borrow 10,000, 15,000 just to go fix that car. But that same person may, go to the hospital and probably does not really see the need why a test should cost 3,000. So it's not really as, I'm not saying that everybody has money. It's kind of intertwined. It's not really as if I don't really have the money, but that maybe is not my priority. And that's where us as clinicians too, that patient education part of it is also very critical. It's the same as getting a blood transfusion. It's like a life or death thing, right? If it means this, try to get it and let's try to figure out what is wrong with you. Yeah, thank you so much.
Yeah, so I want to add something, Kenji. I haven't worked in Cameroon and in the diaspora. I will tell you, education is a big part. I know we keep talking about finance. Finance is a part, but education is a bigger part. Bigger. Why? Because we do run a lot of tests for these patients, which are not necessary at times, and which are of no value, and which are more expensive than necessary tests that have to be run. So I'm going to tell you that from firsthand. I worked in a SEMA in Cameroon. I worked in a district hospital. I worked in the regional hospital. There are multiple diabetic patients who can afford for cultures. Question is, who is asking for them? Who is demanding them? And truly, we have Cameroonian physician nurses are very smart. We need to think about algorithms that were done here and adapt them. Not all algorithms should be transplanted the same way. Our epidemiology of disease is different. In the US, all fevers, most of the time, is never malaria, but Cameroon, you need to rule out malaria. So in any protocol you're doing, a rapid diagnostic test can be done in 1 minute. It tells you there is not malaria. Then you jump up to sepsis. It tells you it's even quantitative. There is 1 plus 2 plus 3 plus. Kenji, you can remember, I think I did work in Cameroon. So if a patient comes in and I do a rapid diagnostic test in 1 minute, it tells me it's not malaria. I need to send a culture. You cannot culture everyone if they are not able to afford it. That's why I'm always of the advocacy. All protocols can be adapted, working with those who are in Cameroon in order to get something that fits our environment, really, because our resources are limited. So we need to do that, but we can do it. I did work in the laboratory in Cameroon as a clinical pathologist. I can tell you that was my #1 advocacy. Even in CHU, I saw 1 blood culture in an adult every 2 weeks, every 1 week. Can you imagine that? Pediatricians were sending it. Why should adults be in the hospital in CHU having fever without us getting cultures? If there is no problem in the mindset of how people look at fevers, these are adults in CHU. And the number of cultures I have in the lab as a clinical pathologist for adults is less than 1 a day. There is a big problem. We need to change. So, well, I was just saying this because I think I'm coming from somewhere that I really did see this in Cameroon. My internet is very poor today. I don't know if you guys can even hear me, but my internet today is very poor.
Yes, sir. Yeah, thank you, Dr. Mona. I mean, with the permission of the moderator, there is a comment in the chat that I love so much. And if you permit me, I really want to read it. I am not in the health field, but now I know if I go to the hospital presenting with fever, or I go with my son presenting fever, and they do a malaria test and it is negative, I could request for other related tests to be done to diagnose the cause of fever. I think this is so great, right? Like, this really warms my heart because we need to be advocates of our own selves. It's not only in Cameroon, even here in the US, there are times that I insist that, hey, you have to test me for this because this is how I feel. So I feel like if this education also goes to the public, because there's also that public pressure, we can't negate when it's like, hey, doctor, you must give me something, right? Like, it's like, if I go to the hospital and they don't give me a medication, it's like that doctor does not know what he or she is doing. And I may never come back to that health center again. it's just more of an educational thing where I don't know who is directly responsible for giving, you know, some of this education out, but that is really great. So that statement really caught my attention. It's like the person needs to rename him herself, because I think most people use the link that I sent and it's like my name that is appearing throughout.
Yeah, and Dr. Kenji, I'll tell you, when I was still an internal medicine resident who died in the middle of New York at Cornell, it was a whole who was treated for sepsis, but nobody considered malaria, and she just visited Nigeria. I'm just giving you an example. This happens everywhere. This is because a mindset also exists where people are searching for sepsis. Malaria woman went to Nigeria 2 weeks ago. Everything was done, the sepsis protocol by them. They got a malaria smear, which was almost 40% positive. She was in ARDS, intubated in the ICU. This is a case of the US. That tells you why protocols are important, but protocols should be adapted to the environment where you work. Malaria causes sepsis. There are 19, those who are here, I think when I started in Cameroon, they have 15 critères de polygraph, and Jean-Claude Bagna, Jean-Claude Cate, sorry. Those are things that you can see. Malaria can mimic everything else. This lady came from Nigeria here with fever, sepsis, initiated sepsis protocol, cultures were drawn. She was started on broad spectrum antibiotics. She was not getting better. In less than a day, she went into ARDS, intubated in the ICU, died. Someone later on decided to do a peripheral smear, falciparum, malaria, Plasmodium falciparum, positive. Getting at the time, Atemete or Atesune was almost impossible. That was so many years back. By the time they got it, this patient had died. This lady had died. She was just 34 years old. And was a big M&M in that hospital and got to a point where people had to really be able to advocate even for the Department of Health to have artesunate available and even make them available to hospitals before it became approved last year in the US. So this is just telling you that we are not dealing with a problem this is a problem that can happen in multiple settings, but once we're having an epidemiological transition, we should deal with it too and incorporate it.
Okay, thank you very go ahead, Brian. Ok, d'accord. Merci beaucoup. Nous parvenons à la fin de l'émission. C'était prévu pour 2 heures et je vois que la main de Dr. Vivien est levée. Prière d'être bref pour nous permettre de clore la session d'aujourd'hui. Merci beaucoup. Soudainement, elle ne l'est plus. Dr. Vivien, est-ce une erreur de ma part ou ça va? On a répondu à vos questions.
Thank you very much. It's not an error. I'm Dr. Kumba Vivian, and I worked most of my life in Cameroon. I now live in Gambia, almost on retirement. And I want to appreciate Dr. Kenji for this presentation because it has sparked a discussion that has opened my mind to a number of things with respect to what I do now in public health. Just to say that I had a couple of questions and comments, but somehow while waiting for my hand to be noticed high up, the questions and worries have almost all been answered. And I just want to say now that as clinicians, we work according to how we are trained. And Dr. Muno, and I think even Dr. Kenji also raised the what I want to call the challenge of medical training in Cameroon in a way. And I want to appeal to this house to bring to us, or if they can, to even bring to light the challenges of medical training in Cameroon for purposes of advocacy. Thank you very much.
Many thanks for joining us from the Gambia and having working back home. Thank you very much. Thank you so much to everyone who participated today. We are very grateful. Thank you, Dr. Kenji, for your time, for your presentation. Let me put my camera. Thank you for your time, your presentation, I was saying, and for all the knowledge you have shared with us this evening. Merci encore. Nous espérons vous revoir dans 2 semaines. Je vais passer la parole au modérateur pour avoir un dernier mot. Et nous allons clore avec le mot de chairman. Dr. Brian, tu veux dire quelque chose avant la fin?
No, merci beaucoup, Christelle. I just wanted to recognize the presence of Professor Shea Wisonge from South Africa. I don't know if he's able to say a few words, but I just really wanted to acknowledge his presence.
Nothing to say, thank you.
No, merci. Thank you so much, Prof. And thanks a lot for your guidance throughout this initiative as well. Over to you, Christelle.
Thank you. Thank you for pointing that. I almost missed it. Dr. Kate, are you still around?
Yes, somehow
sorry.
still around. I think I had to make sure we finish this properly. I think it's been a very invigorating and interesting session with the topic that is very dear to all of us, fevers, because we were born, some of us having fevers, we will lead having fevers. Probably, I should not make the last statement. So, but fever is something which we have, and we are called to see patients and see people struggling with fevers. I think personally I've learned a lot today, and looking forward to the parking lot to continue some of our discussions with Kenji. Thank you.
Definitely. So, après cette session, nous avons le parking lot où nous échangeons, mais hors enregistrement. Donc, nous pouvons faire du networking et discuter en plus pour les questions qui n'ont pas été répondues. On peut échanger avec Dr. Kenji, avec chacun des modérateurs. Donc, nous vous invitons aussi à participer à cette 2e étape. Chairman, à toi la parole et merci beaucoup. Au plaisir de vous revoir dans 2 semaines.
Yeah. Well, thank you, Christelle, and sorry for talking very much during this session. It's a very emotional topic for me. I think one of the main reasons I did medicine biologists in Cameroon was because of this specific topic. And I was an advocate of this topic before ever getting to internal medicine and oncology in the US. Why? Because I think we have a good model in Cameroon. I'll always say, no matter what you see, Cameroon always has a good training model you can emulate, and it's the pediatricians. I don't know if it goes down to every other specialty. I think pediatricians in Cameroon are good at ruling out other infections, especially where it's pediatric trained. If you get to them, and if that advocacy can go over to other practitioners and they can take it over to internal medicine and to surgery and other things, pediatricians are good at ordering C-reactive protein, erythrocyte sedimentation rate. They are good at ordering cultures to all their patients who come in, especially when they need it. And they are very good at also having data that guides antibiotic stewardship. If I can recall my pediatric rotations, almost everything I learned in the art of practicing infectious disease other than tropical medicine, which are 2 different things. Infectious disease other than the sub part of it, which is tropical medicine, was from pediatric background. Now that needs to be emulated into internal medicine. We need to know that diabetic patients are more at risk of getting infections from real infections than from malaria itself, and treated appropriately. All the different osteomyelitis that are not diagnosed, and get cultures for those who can afford it. And those who cannot afford it, there is whole system in place now in Cameroon to get universal health care. There are systems in place for directors to actually do subventions for patients who cannot afford to rule out tests. Those are things I could do in Cameroon. So I think that we should get to a mindset where we are able to think about that we are developing. We are no longer really into typical tropical diseases the way it used to be. There is a transition of health. Our patients are getting diabetic. There are sickle cell patients that are leading, and they are asplenic, and they are dying of sepsis, and nobody is catching it early. Cultures need to be done to give them the appropriate antibiotics. We need to think about antibiotic stewardship, that we don't destroy antibiotics for the future of the world itself. So I think, Dr. Kenji, I want to thank you for stepping in and within a short notice and doing this wonderful presentation. And we're going to continue the discussion, Christelle. And I think this is a discussion that I know that Cameroonians are capable and they are well trained. We just need to orientate, especially, I always say this goes to the level of the general practitioner orientation, because that's where specialists are few and they know what to do, but the patients never reach them. We need to train our nurse practitioners, our nurses that see patients initially to collaborate with the labs. There are multiple labs that can do cultures, but I know they spend their whole time not doing any cultures. That I can tell you for many hospitals I worked there. I told you the case of CHU. We did cultures for all pediatric patients, few for adult. Nobody sent it. Nobody requested for it. So we could not do it for them. So that's some of the things that I have learned. Platforms are becoming cheaper. NGS that we do in oncology used to be $1 million to do a next generation sequence. About $100 million came to $100,000, came to hundreds of thousands of dollars. Now it's affordable in Africa and Africans can do it. So thank you very much and see you all in the parking lot. I want to thank everyone who is here today. And as Elvis said, we have a working group with the minister and our own rapporteur is here, Dr. Samuel, which would give you guys a feedback in the next, at least in the next month about what we are doing. So thank you very much and God bless you all. And Krista, over to you. Or is that how we end?
Yeah, that was the end. Thank you so much.
Okay,
Happy
so
weekend.
please.